So good afternoon to one and all here. Thanks for joining us today for this wonderful session. First of all, I would like to thank the IMA branch Tirupur for organizing this online CME with the credit has. Special thanks to the President, Dr. Saroja ma'am and her whole team. Then I would like to thank my moderator, our respected and beloved professors, Dr. Ramasamy sir, who always support us, not only us, all the juniors and end dermatologists who are coming to Tirupur. Thank you, sir. And I want to appreciate Dr. Pradipa, who is a good friend and colleague of mine, who gave a wonderful presentation about the skin disorders in summer. And a special mention to coordinator Dr. Rahul Jodi sir, who made this technically possible with the good arrangements. So over to the session. So my topic is about an approach to hair loss. In this session, I'm going to cover about these topics. First is introduction of hair and its growth phase in the hair cycle. Then what is alopecia? How to assess the alopecia by taking how the history taking, clinical evaluation and lab investigation, and few special techniques to assess the hair loss is there, and classification of alopecia, that is non-scarring and scarring types, will be discussed in this session. So coming to the introduction part. So our body is full of hair except in few areas like palms and soles. Our scalp occupied more than 1 lakh pigmented terminal hairs, and the density being 120 hairs per square centimeter. So hair grow at the rate of 1 centimeter per month or 0.35 millimeter per day. So the shedding of hair up to 100 hairs per day is normal. So coming to the hair cycle, each and every hair follicle undergoes a cycle, that is the growth phase. In this cycle, there is a long growing period called ANAGEN, which lasts for 3 to 6 years, and followed by the short transition period called CATEGORIZATION, which lasts for 2 to 3 weeks. And then there is a resting period of the hair called TELOGEN, which lasts for 2 to 3 months. Once it has taken the rest, it will fall off from the hair follicle, that is the release phase, which you used to call this exogen. Then after exogen, the new anagen comes out from the hair follicle, and this cycle will rotate in a cyclical manner. So in the scalp, there is asynchronous mixture of both anagen and telogen hair in the ratio of -1. So each and every hair is replaced once in 3 to 5 years. So one hair undergoes 10 to 30 such cycles in a lifetime. So coming to the hair loss. So hair loss is the general term which is pronounced by the patient, by the physician, and by all. And another term is the baldness, but medically it is termed as alopecia and sometimes hypotrichosis. So how this term alopecia derived from? It is a Greek word called alopecia, from where they derive this term alopecia, which means loss of hair. The alopecia denotes the mange on foxes. Mange is nothing but bacterial infection occurring on foxes, which results in hair loss. So this term is derived from the Greek word called alopecia. So the definition for hair loss is, that is alopecia is the partial or complete absence of hair from the areas of the body which normally grows. Okay, sir. So the patient will come with many stories. They will say shedding of hair, there is thinning of hair, and there is a receding of the hairline. My hair became voluminous. My hair became shortened. There is a breakage in my hair. My hair is not growing beyond certain length. I'm not unable to cover the scalp. So this kind of stories, they will be presented with us. So sometimes they will be more distressed and they will cry in our clinics and in our OPD. They will bring the hair in a plastic bag and sit and they will cry literally. So going to the assessment, the first and foremost thing which is important is history taking. So the age of the patient, the duration of the illness, whether it is acute or chronic onset, and if there is any associated symptoms, any signs of inflammation, itching, pain, everything should be encountered. And other histories which are important are comorbid conditions, whether they are having any systemic illness, diabetic, hypertensive, or any other illness, and any drugs taken for that illness at the present or in the past, then any family history of hair loss, and about the nutritional supplements, whether they are in diet or in the loss of weight, they are having loss of weight, and their psychosexual behavior, and what are the practices they are taking for the hair care, what cosmetics they are using, everything should be encountered in the histories. When coming to the clinical examination, it is examining the scalp. So on seeing the scalp, first you have to assess the whether the underlying skin it has scarring or not. So if the first thing we have to divide whether there is a scar or it is non-scar. Then we have to see for the pattern, whether the hair loss is a small patch or multiple patch or there is a diffuse hair loss. Then you have to assess the quality of the hair, whether the hair is in normal texture or a normal caliber, whether it is thinning, and if there is shedding is there, you have to examine, you have to ask or examine whether the shedding is coming to affected by root or contributing to the breakage of hair. Okay, fine. Okay. So based on this history taking and clinical evaluation, we can categorize the hair loss as non-scarring alopecia and scarring alopecia. So otherwise called as non-cicatricial or cicatricial alopecia. In non-cicatricial alopecia, you can visible the follicles clearly. But in the cicatricial alopecia, the follicles are not visible. Then, based on this, we will classify the alopecia. In the non-cicatricial alopecia comes the androgenetic alopecia, telogen effluvium, alopecia areata, traction alopecia, and trichotillomania. In cicatricial alopecia comes the inflammatory dermatosis condition like lichen planus, SLE or DLE, MORPHEA or scleroderma, infections, any bacterial, viral, or fungal, and sometimes physical trauma like injury and burns. Then based on the pattern, it is classified as a localized hair loss and diffuse hair loss. Localized hair loss are seen in alopecia areata, traction alopecia, and trichotillomania, and diffuse hair loss are noticed in androgenetic alopecia, telogen effluvium, and hair shaft disorders. So based on the texture of the hair, and whether if there is thinning is there, it is always seen in androgenetic alopecia. If the shedding is by root, then it is telogen effluvium, alopecia areata, and scarring pattern of alopecia. If the shedding by breakage of hair, then it is infection, hair shaft disorder, or physical damage, and trichotillomania. So these are the common causes of alopecia. So all throughout the world, the commonest being the androgenetic alopecia, whose incidence is 68.8%. It is noticed both in males and females. Followed by that comes the telogen effluvium, which occupies the incidence of 11.35%. But this after the COVID epidemic, it is more increased. The actual incidence is not updated now. Then comes the other alopecias. So triggers. So for all type of alopecia, for all type of hair loss, whether scarring, non-scarring, localized or diffuse, there is always some precipitating factors, the triggers. The triggers are physical stress in the form of major illness, high fever, post-surgeries like that, and emotional stress, post-traumatic or any psychiatric illness, any major life accidents, and main thing is sleep deprivation. Then comes the nutrition where iron deficient anemia and other anemias plays the main role. Then hormonal factors, pubertal, pregnancy and menopause, where we physiologically face the hormonal imbalance, and in thyroid, both hypothyroid and hyperthyroid, everything will cause hair loss, and androgen excess will plays a role in androgenetic alopecia. And drugs, which includes mainly chemotherapy and oral contraceptive pills. Not only these, many blood thinners, antihypertensive, antidepressant, everything will result in hair loss. Then genetic predisposition always plays in many alopecias, particularly in androgenetic alopecia, autoimmune role, particularly in alopecia areata, and cosmetics. So cosmetics like perming the hair, ironing the hair, using bleachers, dyes, everything will trigger the hair loss. Then coming to the evaluation techniques, there are simple hair evaluation techniques which can be carried out by the patient and also by the physician. These are daily hair counts. This can be carried out by patient itself. Then comes the hair pull test, hair cord test, hair wash test, then trichogram, trichoscopy, and scalp biopsy. So daily hair count. Ask the patient to collect the hair after each and every combing and after rinsing of the hair in a particular day. And on the day, if the count is less than 100 hairs, means it is very normal. After shampooing, if the collection is up to 250 hairs, means it is also normal. So this thing we have to explain for the patient that what is the normal hair fall is. Then come the hair pull test. This is carried out by dermatologist or physician. This is otherwise called Sabrot sign. Or 60 number of hairs are grasped between the thumb and index finger and pulled vertically with a firm pressure. If there is a loss of hair less than 6 means it is normal. If the number of hair is more than 6 out of 60 means definite hair loss is there. Then comes the heart test. We will use the white card for the black hairs and black card for the white hairs. So keeping the card behind the hair up to the root, we can assess the length of the hair, size of the hair, overall caliber of the hair. So we can assess the miniaturization of the hair, thinning of the hair, split of the hair, like that. And coming to the standardized test called modified wash test. This is nothing but the shedded hairs are collected after rinsing in a wash basin by covering the drainage with a gauze. Then the hairs are separated and counted. Then they divided it by its hair length. The hairs less than 3 centimeter and the hair more than 5 centimeter. If the hair less than 3 centimeter means it is nothing but telogen vellus hair. So this test is mainly used to differentiate between telogen effluvium and female pattern hair loss. In female pattern hair loss, it is nothing but androgenetic alopecia in women. There is loss less than 100 hairs with more than 10% of telogen vellus hair. In telogen effluvium, the loss is more than 100 hairs with less than 10% of telogen vellus hair. So trichogram. This is nothing but we will collect the hair, 60 to 80 hairs are grasped and plucked from the root, and they are taped side by side after trimming the length over a white cardboard using a sellotape and observing under the microscope to evaluate mainly the hair root. And by evaluating the hair root, we will arrive what phase it is in, whether in anagen or catagen or telogen. So results are expressed in the ratio of anagen to telogen. Trichoscopy. It is now a new trend. Everything is by scopy only. Even we are using dermatoscopy, trichoscopy for all clinical evaluation. So by using the scopy, we can, this allows magnified observation of the following like hair shaft and their opening, follicular opening, and the perifollicular epidermis and their blood vessels. So these are few trichoscopic pictures by which we can assess some hair loss, like yellow dots. These are the yellow dots which can see in the peripilar, that is in the female pattern hair loss. These are the black dots noticed in alopecia areata, and these are the whitish band which are present in hair loss, that is lichen planus, and this is the normal thing. Then another investigation is scalp biopsy. So this is to mainly differentiate whether it is scarring or non-scarring forms and to confirm the other inflammatory dermatoses like LP, DLE. Here we have to take deep biopsy samples up to subcutaneous plane because the anagen root are deep inside the subcutaneous plane. Then both horizontal and vertical section of histopathology is always needed to assess the pathology. Then coming to the assessment by blood investigations. So the basic tests which are useful to arrive at diagnosis for a hair loss or complete blood count with a complete iron profile, serum iron, ferritin like that, and other vitamins like vitamin B12 and vitamin D, thyroid function test, serum VDRL to rule out the syphilitic cause, ANA to rule out connective tissue disorder. Then endocrine investigations includes androgen index, serum testosterone levels, dihydroepiandrostenedione levels, prolactin, hydroxyprogesterone, and estrogen levels. So we have completely make an assessment using our history taking, clinical evaluation, then hair evaluation techniques, and by investigation, we arrived at some diagnosis. So the alopecia mainly classified as a non-scarring and scarring alopecia. Now we will focus about the non-scarring alopecia. I am going to discuss only the common things. So the first is androgenetic alopecia. The synonyms for this are pattern alopecia, male pattern hair loss, or female pattern hair loss. This is the most common alopecia affecting both sexes, the incidence being more in men. So the name itself tells about the cause. Androgen is the reason. Genetic, there is a genetic predisposition. So genetic predisposition plays the major role and DHT plays the key role. So what happens here is all the terminal hairs are converted into vellus hair, which result in follicular miniaturization, which is a most hallmark feature of androgenetic alopecia. Once it starts, it usually progressive. Then coming to male pattern hair loss and female pattern hair loss. In male pattern hair loss, the frontal hairline will be receding. There will be thinning and miniaturization of hair. It commonly noted in frontal, central, and parietal scalp. But in female, it is different. The frontal hairline is often sparse. I think the picture is missed here. Only the hair loss will be in the line of parting. So there will be widening of the central parting. There is a progressive thinning of the hair mainly in the central parting of the scalp. Then management of androgenetic alopecia includes the 5-alpha reductase inhibitor. So 5-alpha reductase is the main culprit in the androgenetic alopecia. It is the enzyme used to convert the androgen to dihydrotestosterone. This dihydrotestosterone combines with the androgen receptor in the hair, which makes the hair into a follicular miniaturization. So by blocking this enzyme, everything will be blocked and the hair will be maintained. So the common 5-alpha reductase inhibitor used are finasteride and dutasteride. Alpha-triadiol is the newer one. It is a topical 5-alpha reductase inhibitor, but it's not available in India. Then coming to other anti-androgens like spironolactone, flutamide, all will help the arrest of the hair fall, but not the growth. So for the growth, we should depend on minoxidils. So minoxidil is a potassium channel opener, which causes the vasodilator in the scalp that helps in the supply of the blood and oxygen to the hair, and thereby it increases the hair growth. It is available in many percentage, 2%, 5%, and 10%. And the most alarming and most famous one is the PRP, that is the platelet-rich plasma. Nowadays, everybody landed up with the hair loss and asking for PRP. Can you do PRP for me like that? So next comes the hair transplantation. This is also becoming more famous nowadays. Even asking without, they won't come for treatment and all. Directly they will enter the clinic and ask for the hair transplantation. And whether you are doing or you make a referral to hair transplantation like that. Then coming to the next one, TELOGEN effluvium. It is nothing but it's the acceleration of the hair loss cycle. So more hairs are in telogen phase than in anagen phase. The shedding of hair can occur up to maximum of 300 hairs per day. It is exclusively seen in females. Usually triggering factors will be present, and the pull test, what I told in the evaluation techniques, always positive in telogen effluvium. It is divided into acute type and chronic type. Acute type, there is an immediate anagen release, definite known trigger will be present, and the hair loss will occur only after 2 to 3 months after the triggering factor. And it remains with a few months in 95% of individuals. There is a temporal thinning that you can see in the picture. There is a short hair and temporal thinning seen in the scalp. Then comes the chronic telogen effluvium. It lasts more than 6 months. It always follows the acute telogen effluvium, and there is a shortening of anagen phase, shorter regrowing of hairs in both frontal and bitemporal areas. Usually, no triggers will be made out in this chronic telogen effluvium. So, management of telogen effluvium, first thing is the reassurance and counseling. The hair will regrow within a few months. That we have to make out first. Then treat the underlying cause. What are the precipitating things that have happened to them? Find out and treat that. Then dietary supplements, both in the form of food and in the form of drug supplements like iron, more than 300 milligram TDS, then biotin 5 milligram per day, and cysteine 500 milligram per day. These are the common minerals we use for the maintenance of the hair loss. And then foremost thing, topical minoxidil is given for all kind of hair loss. Then comes the anagen effluvium. This is mostly chemotherapy induced or radiation induced. It happens 1 in 3 weeks once started the chemotherapy. It completes, the hair loss completes in the period of 1 to 2 months. 90% of the scalp will be involved. There will be obvious baldness, and this will be reversible once the chemotherapy is stopped after 3 to 6 months of stoppage. The radiation-induced anagen effluvium either be reversible or permanent. Then comes the alopecia areata. This is the non-scarring alopecia, can occur as a smooth patch of hair loss, sometimes multiple patch, sometimes the whole scalp, complete involvement will be there. It can occur at any age, starting from second decade to fourth decade. It has its autoimmune etiology. Spontaneous regrowth is possible in 80%. So it has a spontaneous resolution. Usually it occurs, the resolution occurs within 1 to 3 years of period. And the treatment includes, mainstay of treatment is steroids only. Topical, systemic and intralesional, everything can be done in alopecia areata. And then comes the topical immunotherapies. These are the types of alopecia areata. The first picture shows multiple patches going for a complete pattern. The second picture shows the alopecia subtotalis. The third picture shows the totalis. The whole scalp hair is involved. Then, if there is involvement of eyebrows and eyelashes and body hair, we used to call it as alopecia universalis. And the last pictures is the alopecia areata barbae. It can happen in the beard area also. Then trichotillomania. This is a psychological condition. The patient will have the persistent hair pulling behavior. They are more anxious before pulling and they are satisfied after pulling out the hair. They will present with the asymmetrical patches. Mostly these patches are seen in the accessible sites like frontal areas and vertex areas. The main treatment is psychotherapy and behavior therapy. Sometimes antidepressant SRIs may be helpful. Then traction alopecia. This is trauma-induced. It is caused mainly due to the continuous excessive pulling of hair by tight hairstyles. It's a common along the scalp margins. So the main advice we have to give is loosen hairstyles along with topical minoxidils. So coming to the scarring alopecia. So scarring alopecia can occur due to infection, any kind of infection, bacterial, fungal or viral. In bacteria, common impetigo, pyoderma, folliculitis, cellulitis, everything will result in a scarring alopecia. The first picture shows the pyoderma over the scalp occurring in the childhood, causing the scarring alopecia. The second picture is the tinea capitis. One of the type is called keria. There is a boggy swelling with a crusted blob over the scalp, which resolve with the scarring alopecia. And then sometimes herpes zoster, herpes evens, herpes simplex occurring over the dermatome pattern involving the scalp can result in the scarring alopecia over the scalp. Then another infection, one of the important infection is syphilitic alopecia. In syphilis, particularly in SY2, that is secondary syphilis, we will face this type of alopecia that is called moth-eaten alopecia. Then comes the MORPHEA. It is nothing but localized scleroderma. There is a condition called N50-Zaber, where there is a linear atrophic scar-like presentation involving both the scalp and the forehead, which results in scarring alopecia. Then comes the lichen planus. There is a type called lichen planopilaris, which particularly occur over the scalp along with scarring. Then the discoid lupus erythematosus, sometimes the chronic type of LE, an acute type of LE with discoid rash present in the scalp, giving a scarring alopecia. And these are all about the scarring alopecia. So I overall covered the alopecias happening commonly in our setup and how to evaluate with the assessment of everything clinical, lab, and evaluation techniques. So I think it may be useful for your practice. If any doubts, you can ask now in the discussion point. Thank you so much. Thank you for your patient listening.
Thank you, ma'am.